be covered, behavioral emergencies covers a large area of information. So we're gonna get started on this, okay? And I'm just gonna kind of go over the key things that you're gonna need to know when you go through your psychomotor and your cognitive testing, so that you can apply this information to those situations. And so, and you know, basically this area applies the fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient with a behavioral emergency. And so we're talking a little bit about psychiatric. You know, just about every patient that you encounter will have some form of a psychiatric issue. Many of our patients have those. So you're not just dealing with what you're called for, the chest pain, the difficulty breathing, the injuries. They may have a psychiatric component to what you're dealing with. And so you also have to deal with that issue, and you have to do it appropriately, or you will have many problems, I promise you. So behaviors that pose a risk to the EMT patients and the basic principles of the mental health system. And I'm going to tell you, I know this is a personal opinion, but we are not, in this country, we are not dealing with mental health the way that we should. And in fact, there are for example, the one of the key things that I'm keyed in on is the number of veteran deaths per day in this country that right now are not being attended to, and it's 22 per day. So you'll see that number 22 right now, and who knows where it'll go. And even in civilians with mental health disorders, a lot of times you'll see homeless people that have mental problems, that are out on mental or psychiatric issues. They're homeless. Some of them are addicted to drugs. Not all of them, but many of them are, and their health is just so poor. And then when they come into the ERs, it's a nightmare. So those are big key issues. Assessment and management of acute psychosis, suicidal risk, and agitated delirium. And then EMTs often care for patients experiencing behavioral health emergencies. The crisis may be the result of acute medical situation. We deal with that significantly because a lot of the things that we deal with are acute illnesses and injuries. The mental illness itself, so a lot of times these people that have mental illness and they're not directed, some of them get really good treatment, and some of them are guided in the right direction because they have appropriate support systems. And support systems is a key issue with these patients. So dealing with the mental illness, mind-altering substances. How many people have already ran calls in your young lives that the patient has taken some mind-altering drug?
Hell yeah.
Yes, and that is very common, commonplace. And so, and then you're going to have to realize that you have to come to like, hey, let's try to find out what they've taken. So you know, like, oh, okay, they took this. This is why we're dealing with this. So yeah, you're gonna have to do that. Stress, and stress not just on them, but on you as providers. Because if your stress response is making you act inappropriately, you're trying to run into a situation and then you're not looking for safety things, or you're in there and you're talking very quickly, very loudly. Patients don't like that. And often you're going to have people say, we've talked about the patients that are hard of hearing yesterday and how you can deal with them. But if somebody tells you someone's deaf, how many times have you seen people, hey, can you hear me? They're deaf. You're not going to hear you. Or if they are hard of hearing, do they have their hearing aids in? Do they have hearing aids? Do they need a support system to get them there? Well, just like that, for mental illness, support systems are a key thing. You need to get access to mental health, psychiatric treatment, and those are big deals. And we have some businesses here that deal specifically with patients who are addicted to substances. And so we may be called there because what do they have to do before they accept them as patients? Anybody know?
Medically clear them?
Right. You have to get them medically cleared. Are we as EMTs and even medics authorized to medically clear a patient in situations? No. The answer is no. We are not. We are able to go there, and if we're called to an area, to assess the patient, because what are we really good at? We're really good at assessments, aren't we? And we can get people like, hey, they really need to go to the hospital for this reason, or I'm not seeing anything, but we cannot medically clear them. So stress is a big issue, and then there's other causes for patients to have behavioral health issues. Sometimes it's just that the person was brought up in a very entitled home. And that just means that they're used to having everything that they want and need and more, and they're just spoiled. And at some point, most people experience an emotional crisis. Doesn't mean that everyone develops a mental illness, and with patients that have problems such as behavioral, don't jump to conclusions. Don't be like, well, oh my God, she's psychiatric, and that's been a big issue that they look at women and go, oh my God, they're having an emotional crisis. And you see people do that all the time. And sometimes men are emotional just as well as women. And I've seen it. And then people are like, oh my God, he's having an emotional crisis, but who knows when you're going to reach a point where you cannot cope, and that's a big thing, learning to cope with something. And if you can't, some people cry out, some people learn ways to cope, such as going to the gym, reading a book, swimming, doing things that they like to do to deal with the stresses of everyday life. And you'll have to find your own way of coping with a lot of the things that you're going to see in EMS even. So you have to learn, you're going to have to learn about that, and if you need help, you're going to have to learn that I can reach out to resources. That's a big thing, learning your resources. Not saying, oh, it's weak to reach out for help. It's not. And I know a lot of people do jump to conclusions on people that have behavioral or psychiatric things, and there'll be like all these judgmental things towards them. Don't do that. That's never professional. It's never acceptable. The most common misconception is that if you are feeling bad or depressed, you must be sick. That's not true. There are many justifiable reasons for feeling depressed. Some people who are going through stressful things such as divorce, death of a relative or friend, that's a big key one. And you have to keep an eye on yourself and on others and on your patients. And you have to be compassionate. In this field, we cannot teach compassion, but if you don't have compassion and you're in this field, you probably should not be in the field. Some people believe that all individuals with mental health disorders are dangerous, violent, or unmanageable. And just to let you know that there's only a small percentage that fall into those categories. And EMTs must be exposed to a higher proportion, maybe exposed to a higher proportion of violent patients. And I've had them. I've had patients kick me. I've had them cuss me. I've had them throw things at me. I've had them pull my hair. You know, people in some situations do not realize the actions that they're taking, and some do. And, you know, there are consequences for assaulting public health workers. So, you know, that's bad on them for doing those things if they're aware. And then communication is key. If you come into a patient that's having a behavioral or psychiatric issue and you're judgmental, or you're just like, so do you want to go to the hospital or not? That is not a way to gain rapport with your patient and or people that are with them, their family, their loved ones, other bystanders, and it reflects poorly on EMS. And you may be able to predict violence. Like if you see someone that's acting out, and I know some of you have been on calls, I think you were the guys that were on the call where the person was very violent. Did you go on the call? Do you remember that call? I'm gonna mention it because you know it's a HIPAA thing.
I haven't been on a call with you ever. So.
No, it wasn't with me. It was with someone else. But the patient was very violent, was kicking and thrashing around, and there was potential for our folks or any of the folks to get injured. And of course, we don't want a patient injured either. I mean, but you know, sometimes they do things to injure themselves that you can't stop.
So it's Mr. Fuckass is gonna get a good show.
Yes, yeah.
So behavior is what you can see of a person's response to the environment and his or her actions. So over time, people learn to adapt to stress. Not all people. I'm going to say that that's a false. Not all people learn to adapt. Some don't. And some have really, really horrendous problems. And then sometimes stress is so great that the normal ways of coping do not work. So if you normally, say that you're a runner and you normally go out for a run and that is what is stress relieving for you, or sitting on your front porch with your dogs or talking to a friend, sometimes those things don't work. And sometimes talking to a friend is not helpful because sometimes, what do friends do sometimes? They'll tell you what you want to hear.
What?
And they won't tell you the reality of it. Yes.
Really?
Oh my God, please. But reactions to stress that are acute and those that develop over time can create a crisis. And that's why we say sometimes people are in crisis. So we need to deal with that. So if someone's in crisis, then you have to deal with that. So a behavioral crisis includes patients who exhibit agitated, violent, or uncooperative behavior, or who are a danger to themselves or other. And I can tell you, I've been on many calls where this has been the situation. And sometimes these things could have been alleviated by someone being therapeutic in their communication. Something as simple as that.
Some people just want to be heard.
Yeah, and that's so true, and I want to comment on that because sometimes we need to shut our mouths and let the patient or the person who is exhibiting crisis or problems to just vent. And that's sometimes what someone needs to do to normalize themselves so you can deal with them more effectively.
It's humanizing.
Yes.
They feel dehumaned.
Yes. And if you talk down to them, so say that you're coming up, they're sitting down, you're walking up to them, and you're in a higher stature of them, they think that you're looking down at them, literally, that you're talking down to them, you're belittling them. So sometimes even just coming down to their level, and then like kids, that could be scary because they're just like, oh my God, look how big this person is. And if you come down to their level and it's like, it's therapeutic for them and it's not as scary. And it looks more like, that you're a friend or you're, like in a parent role. So mental disorders are common throughout the United States, affecting tens of millions of people each year. And I want to emphasize that number, tens of millions of people each year. And a psychiatric disorder is an illness with a psychological or behavioral symptoms that may result in impaired functioning. And then the anxiety disorders, those are among the most common. And I can tell you, I've dealt with someone on a personal basis, many bases, and in a professional role with people who have anxiety. And so anxiety disorders include general anxiety disorder, panic disorder, social and other phobias, post-traumatic stress disorder, and obsessive compulsive disorder. I've dealt with patients in every single one of those categories. And I'll tell you, it's a challenge for me, often it's a very big challenge. And you have to, you're trying to de-escalate them. They're in this, for example, I'll give you a good example. I am terrified of snakes. So if you bring a snake near me, I do not encourage you to do that.
I'm gonna bring a snake.
I can tell you, I do
have
not
that
encourage
snake.
it. I do not encourage it. I am going to be in a panic disorder, and I will not be responsible for my actions.
His name's
And then, there are people who have phobias of spiders. I don't like heights. So it's like, I've rappelled before, and I've also bungee jumped, trying to deal with that phobia. It did not work. It did not work. I was terrified when I was bungee jumping. I felt really cool when I was rappelling but I had particular people on safety lines, belay lines, and someone halfway down. I had particular people there that I trusted. So trust is a big issue. How many of you have had a thing and you're just like, look, I don't trust them to deal with this. Certain things that there's only particular people that you'll trust in situations. And then a lot of your military folks have PTSD, not just them. There are people out in just the generalized public that have PTSD from various things various events that have occurred. So, and if they've had there could be something that triggers, and triggers are a key issue in that situation. And then obsessive compulsive disorder, I'm going to tell you, I think I really had that with a certain thing, because I would go and be like, okay, I'm getting ready to leave for work, I need to make sure the stove's off. Or, just different things. But I know the stove was a big thing, and I'm like, I need to make sure the stove's off. And then I'd go and get my stuff and get ready to go and go, well, did I check the stove to make sure it was off? And then I would come back and do something else, and I would go back, check the stove again. I don't know if any of you have ever done things like that, but that's an obsessive compulsive disorder. So the U.S. mental health system provides many levels of assistance. Professional counselors are available for like conflicts and parenting issues. And that just says marital conflicts. There are other conflicts they deal with too. More serious issues are handled by psychologists, and then severe psychological conditions require a psychiatrist. And so sometimes medications are good, sometimes medications aren't the answer. The US, and then it just talks about most psychological disorders can be handled through outpatient visits, and then some people require hospitalization in a specialized behavioral health unit. And then those people get these stigmas, so it's like, oh God, that's a psych patient. And you know, in reality, the people that are getting the psychiatric or mental health help are more healthy than other people. So those are key things. And then social and situational stress. Sometimes people go into social situations and not feel comfortable. And I'm sure that you have heard of people going like, you know, you're just not a very social person, you know, or you're antisocial. Some people do have antisocial personalities. They do not like to be able to get out, and they don't want to rub elbows with these other people. No, Jane's very social actually. She's just.
Sure, Jane's social.
So then there's such diseases such as schizophrenia, physical illnesses such as diabetic emergencies. We've talked about those today big time. Chemical problems such as alcohol or drug use, and then biological disturbances such as electrolyte imbalance. Believe it or not, an electrolyte imbalances can cause you to have all kinds of behavioral or psychological features. And then we don't want you to be responsible for diagnosing the underlying cause of a behavioral crisis or emergency, but you should understand the two basic categories of diagnosis a physician will use, and they're organic and functional. And organic disorders, it's an organic brain syndrome. It's a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiologic functioning of the brain tissue. So that's functioning of the brain tissue. And then there are other causes like sudden illness, traumatic brain injury, and the patients, a lot of our patients can have those easily. Seizure disorders, we talked about those already. Drug and alcohol abuse, we talked a little bit about that today. Overdose, and we talked a little bit about withdrawal. Withdrawal can be very, very bad for patients. And then diseases of the brain. And then, just talking a little bit more about organic disorders. Altered mental status can arise from hypoglycemia, hypoxia, impaired cerebral blood flow, hyperthermia or hypothermia. We've talked about those the last couple of days. And then functional disorders, the physiologic disorder that impairs bodily functions when the body seems to be structurally normal. And examples are like schizophrenia, anxiety conditions, and depression. And I know that there are a great number of people that suffer from depression. And, you know, I mean, simple things. And you never know when people are going to actually suffer from depression for something that you might not be impaired by, but they certainly are. And then all regular EMT skills are used in a behavioral crisis. You're the investigator. You need to go and investigate, find out what's going on with your patient and what can be contributing to these behavioral issues. And then scene safety. In the situations that can be very dangerous for you and your crew, you need to do that scene size up, that scene safety, always first, always. If you go into a situation in which it feels unsafe, it looks unsafe, or it is unsafe, you need to back out. We are not law enforcement. We don't have their skill set. I don't claim to have their skill set. I don't want their skill set, but I just know that that's one of your resources. And do you need immediate law enforcement backup? You better, if you need them, you need to ask for them quickly. The sooner, the better. Don't wait till you get there and you're involved in something and you're trying to work your way through it and you're like, okay, I'm in real danger now. And then you should you stage until law enforcement personnel have secured the scene? I can't tell you the number of times that our unit has had to stage outside until the scene was safe.
You ready to do that?
Yeah, and it happens commonly. And lots of times people walk into dangerous situations. I know that I've walked into scenes where there are rifles, there are handguns, there are beer bottles on tables that can be used as weapons, there are drug paraphernalia, I can't, and there's bats, and I'm not talking about the flying bats, I'm talking about the baseball bats, softball bats, and lots of other things that I have seen, and I'm just like, knives, a lot of, I've seen swords, all kinds of stuff at scenes, and if they use that on you, you're going to be dead, and if you're not dead, you're going to wish you were. So these are really, really important things to figure out. And then always take standard precautions and request additional resources early. So the mechanism of injury or the nature of illness, so the MOI or the NOI that y'all see in the books, determine the mechanism of injury and or the nature of illness, and note any medications or substances that may contribute to the complaint or treatment of a relative medical condition. So if there are lots of meds there, and a lot of times people have what they call polypharmacy, which is like 5 or more medications, you'll see all these medications, and I'm telling you, when you go typically beyond 5 medications, you're gonna have some kind of interaction with other medications that you're taking, and that may be the one that's causing them to act up. So you need to form a general impression. Well, we've been telling you that for a long time, right? So begin your assessment from the doorway or from a distance. And as we've been talking about, when you're doing your assessments, when you've done your scene safety, your body, substance, eyes, and don't be robotic about those things. Oh, scene safety, BSI. And we've had people that have done that. Don't be robotic in that. And do your scene size up, and you're looking and you're going, okay, do I see anything dangerous in this situation in which me or my team is going to be in danger? Perform a rapid physical assessment. Well, we've told you that. I know that yesterday, Jacob, we were talking about that rapid physical assessment that we're going through. And the reason they say rapid physical assessment, because it's supposed to be rapid, right? And then observe the patient closely using the AVPU scale to check for alertness. And y'all all remember the AVPU. Everybody in here feel comfortable with that, the AVPU? Everybody remember that? And then establish a rapport with your patient. I can't say that strongly enough. You can't establish a rapport with your patient, you're not going to do well with that patient. And then most medical or trauma situations will include a behavioral component. I said that from the beginning coming into this. Airway and breathing, I'm not even going to go over that because we've been going over that. You know how to assess an airway, you know how to check for breathing, you know how to fix those issues, and those need to be fixed. Circulation, same thing. You know how to assess circulation, You know how to fix that, right? Everybody in here feel comfortable about those. And just remember, when you have an alteration in any of those, that could be leading to your problem. They're having a breathing problem. They're having a circulatory problem. They don't have an airway. If they don't have an airway, they're not going to be acting too much of anyway. If they're not breathing, they're not going to be acting too much of anyway. If they don't have a pulse, they're not going to be acting too much in any way. But if they have an alteration in any of those, they have poor circulation, they have poor perfusion, they have poor oxygenation. And what part of the body requires oxygenation and glucose all the time? Brain. And that can affect them in a number of ways. So unless the patient is unstable from a medical problem or trauma, prepare to spend time with the patient. And so if they're not unstable and you're not having to fix the ABCs, and you may have a 15-minute transport time to the hospital, keep continued communication with that patient, because that may be your only way of establishing that, hey, I'm safe, I'm good with this person, with your patient viewing you that way. And if the patient views you as one of those things that's like causing them a problem or causing them to be stressed, they're going to act out. And it could be very bad situations because they could be violent in their response. Investigate the chief complaint and obtain a sample history. If you don't know by this point how to investigate the chief complaint, if you go to a patient and you ask them, why did you call 911? I didn't. My wife called and was like, well, what kind of problem are you having today? I don't have any problem. I think it's my wife. So what is their chief complaint? Anybody?
Psychiatric emergency.
So they don't have a chief complaint. If the patient is not complaining of anything, they don't have the complaint. Now, you may have your impression. That will be your primary and secondary impressions. You always need those on your run form. And then obtain a sample history. If by this point you don't know how to obtain a sample history, you're in trouble. But this is very significant. So you're looking at, what does S stand for? Signs and symptoms. And so you're going to get those. What's the A stand for? Allergies. So maybe they have an allergic reaction to a medication and that's why they're acting out. What does M stand for?
Medication.
So they might be on a slew of medications, or maybe a new medication has been added, or they've taken something away. That can also happen and also have problems. What does the P stand for? What did you say? Previous illnesses and injuries. So that can play a key part of what's going on with them. What's L? Right. So can that impact a patient's behavioral issues? So let's say that you as high school students, you go to school, you don't eat breakfast, you've got to study for a test at lunch, you get out of school, you've got to go to work, you're working a part-time job, you don't have time to eat, all of a sudden you're like, man, and then you start acting out. Could that happen? From? What do you think it might be related to? He might be hypoglycemic, right? Maybe his blood sugar dropped, you haven't eaten all day, and you've got a lot of more metabolic needs when you're out doing stuff or doing things. So the metabolic demand on your body is higher. So you're going to be using up stuff faster. And if patients are taking things like, or hallucinogens or other drugs or alcohol, a factor. A big thing today is what? Illicit drug use, right? And that's one of the questions on on Image Trend, which we use. That's one of the questions. And people are not answering this. Has the patient had any alcohol or illicit drugs today? And you can ask that in a very mild way. It's like we have to ask every patient this. Have you had any alcohol or any illegal or illicit drugs today? And some people are going to lie to you. Okay, that's just a fact. But many people will tell you, hey, I smoked a little weed, or, I use cocaine daily, or methamphetamine. Now, some people are not going to admit to that because what do they associate with us when we're coming in uniform?
Police.
What did you say?
Police.
Police. They think that we're the cops. And so we have to tell them, look, I'm not, and I've done this right in front of a police officer before. I am not a police officer. I'm not here in that capacity. I need to know so I can help figure out what's going on with you. And sometimes you have to say that, okay? Those are some of the things. And then you need to report these. When you're giving a report to the hospital, you need to report those things. And there are just questions to ask in evaluating a mental health disorder, and those are in your reading. I'm not going to go over every single one of those because this is just a review of things, not to go over those. And in an unconscious patient, you need to begin your physical assessment, right? And then a conscious patient, they may be able to respond to your questions, but be careful with how you address them. And I don't know, I know, Devin, you weren't with me. No, you weren't with me either. And no, none of you in this room were with me. But we've had some psychiatric mental health calls in our community. And I know that I have been on 2 in particular calls not too far ago or too long ago, that we were on the scene for 3 hours.
Yeah, about something like that.
And that's an uncommon amount of time to spend on the scene. But when you might be waiting for law enforcement, sometimes they'll have to get certain like ECOs, and so sometimes you'll have to wait on them till they get back with that, so that you can legally take the patient, because those have to come from the magistrate, and they have to see a reason for that. You can't just go, I need to get an ECO, and there's different things, and there's 2 in particular things that you'll want to see is a difference between an ECO and a TDO. And some of those people think that those are the same things. They're not. Physical exam, you're going to look at the patient's facial expression, their heart rate, their respiratory rate. You're going to look at everything to get keys, you're like an investigator. You want to get down into the situation and figure out what is going on. And then you have to develop a plan for treatment and transport. And these are another one of those situations in which if there's a refusal, that's a very sticky situation, because you have to look at, is the patient in a situation in which they could harm themselves or others? Are they making verbalizations that are indicating that they're going to hurt themselves and or others? And then you have to go into all these things. Do you have a plan? Well, what is your plan? And sometimes they don't have a plan, but they're making the comment. If they ever make a comment that they want to hurt themselves or they want to hurt others, you cannot leave them alone.
Oh yeah, we did. We had one guy. We were like, it wasn't initially that. It was actually I don't even remember, but yeah, he's a pretty sad guy. Tim was like, "So you thought about hurting yourself recently?" He's like, "A little." Well, I went to the hospital.
Yep, and you do not want to let them out of your sight,
We did.
not for a minute, because those kind of people, even sometimes you'll hear of people doing these little superficial cuts on their wrist.
He wasn't there.
Well, but
Yeah,
what
I
I'm
know
saying
what you're
is
saying.
that is a cry for help. People saying, "Well, I've thought about it," that's a cry for help. You should act. You need to act. And then never let your guard down. If I tell you nothing else, never let your guard down, because they can act out towards you. They're willing to take their own life. Do you think that they might be willing to take yours as well? Like, if they're going to go out of this world, do you think that some of these people mind if they take you and your crew along with them? No. So you have to keep your antennas up, your guards up. If restraints are necessary, you need to reassess and document every 5 minutes. And you have to look, and this has been in media about people using restraints and people dying from people using restraints. Even people being put on the stretcher in a prone manner, and then them cinching up the seat belts, and you not being able to assess their airway. Do you think that's acceptable? If the patient dies, do you think that you will be justified in that? I can tell you right now, you will not be. So you need to stay on your game. Always assess your patient. You're responsible for your patient. Even if someone comes out and law enforcement calls you out to check a patient, if there's a confrontation between you and law enforcement, which you do not want to get in a pissing contest with law enforcement. However, if there is a disagreement about what you should do with the patient, what do you think you should do?
Whatever I feel is better for the patient and myself.
You could call MedCom immediately.
Really?
Yes.
Okay.
Call MedCom and go, "We're on the scene of this patient." Tell them what you're there for, and tell them what your situation is, your assessment of your patient, and that you feel like your patient needs to go to the hospital, but law enforcement is saying no. Or they need specific treatment, and law enforcement is going, "Nah, we're not doing that." Don't take a no answer for if your patient needs care. You are responsible. They are in the custody of law enforcement, but you still are responsible for taking care of that person. Interventions, you need to diffuse and control the situation. Diffusing things, like I can tell you, and I'll give you a good example. There have been calls that I have been on that the patient absolutely hated me. They did not want to deal with me. And one in particular case was a guy who was going through a divorce, and he did not want to look at women.
Fair enough.
He didn't want to think about a woman. He didn't want to look at a woman. And guess who was the person there? Me. And so I switched off with one of my other providers that was with me. It was Glenn Gray. And he was able to talk to this guy and get him calmed down, diffuse him. And then there was a call where this little old lady, and I thought she was just going to fall in love with Glenn. She could not stand him. She did not want anything to do with him, and I had to jump in the back with that
No,
patient.
I understand that.
Yes, it happens, and it's just so funny, and it's when you least expect it. And just remember that sometimes when you're asking patients questions, sometimes you may hit a trigger. You may need to reword your question, because it's something in that question that has triggered something. And, you know, like even, you know, for example, all women of childbearing age are considered what until proven otherwise? Right. So if you ask them, are you pregnant? Maybe they've been raped. Maybe their parents don't know that they're pregnant, and they're just like, oh my God, don't let them say that out loud. You know, so you have to be really, really careful with all of those things. If you think a if a pharmacologic restraint is necessary, ALS is the only one that can do that. And if you go in with the patient, don't let your guard down with assessment, because some of those agents can cause the patient to quit breathing or not breathe adequately to sustain life. So just because you're a BLS provider does not mean that you can't say, hey, it looks like he's only breathing 6 times per minute. You know, or his respiratory rate is really low, or he's becoming cyanotic, or, you know, hey, you know, he's just not breathing well. That is still a good thing, and I don't care if the ALS person gets pissed off, it's still your responsibility. You owe it. We owe that to our patients. I don't want our patients to die because someone wasn't assessing them, someone wasn't looking out after them. And a lot of this stuff that's been in the media about, for example, putting a patient prone on a stretcher and cinching up the seat belts and having a sheet thrown over them and cinching that seat belt up and not assessing that patient, or someone giving, now you're not required to know those very those are medications that can be very lethal, but if someone's given someone a medication and you're on their truck, don't let your guard down. Still assess that patient. Still do your vital signs. Still do your airway, breathing, circulation. Don't ever let your guard down. And then communication and documentation. Documentation, we talked about that. We talked about communication and documentation yesterday. Communicating with people is essential. If you can't communicate with other healthcare providers, if you can't communicate with your team, even, you know, you don't have to be best friends with everybody you run a call with, but you have to be professional and appropriate on calls. Like, you might have a disagreement with somebody, but when you go out on a call, you've got to set that aside and go out on that call. And as far as documentation is essential. And if you didn't document it, you didn't do it. And if you document it in a poor manner and someone sees that, that really tells them, you know, gosh, this documentation was really bad, so I bet their care was really poor. And that's what they're going to think too. And they're going to eat you alive. And that's not a threat, and that's not to scare you. That's just to make you more vigilant and make you realize that, hey, I need to make sure my documentation is good and appropriate. And there's a documentation course by Amanda Loretti, and I highly recommend that course. It will tell you a lot about how to document, how to be professional, and how to get all your key points in there. And then there's psychosis. That's a state of delusion in which the person is out of touch with reality. Some of these things are like mind-altering substances, intense stress. Intense stress can make people do that. Delusional disorders and schizophrenia. And so if they're not in touch with reality, don't let your guard down, because they may, you know, try to do something to hurt you and your team. Guidelines for dealing with psychotic patients. Determine if the situation is dangerous, always. Clearly identify yourself. Be calm and straightforward, and maintain an emotional distance. And I'll give you a good example of that as well. Is I had a patient who she was she had suicidal ideation, and so I know with those patients, you want to be more open with them, but you have to be careful too. But you want to express an open stance. You want to express that I'm here to help you. With your nonverbals, well, she was noticing that like I would keep eye contact with her in situations. I would look away appropriately and try to keep that emotional distance so that she didn't realize it. Where she was like, "Well, I don't like that you keep looking at me," and then in the next few sentences, it's like, "I know you're obviously looking away from me now," and so you couldn't win for lose with her. But so you just have to go, and like, hey, I'll be more careful with that. And even if you want to say things, don't do it. Don't say the things that are in your head that you want to say, and you're just like, I'm sorry, I didn't mean to offend you, I didn't mean that. And because you're trying to get a rapport with them, not tick them off more. And then do not, like I said, do not argue. Explain what you'd like to do. Sometimes when they're going to say, no, you're effing not going to do that. Involve people whom the patient trusts. And I know on one of these psychiatric calls I was telling you guys about, we did use friends that knew her to help get into, so that we could assess her and treat her. And they were very helpful in that way. And then it talks a little bit about delirium. This is a big thing that's happened with patients. It's a condition of impairment in cognitive functioning that can present with disorientation, hallucinations, or delusions. Agitation is characterized by restlessness and irregular physical activity. How many of you have ever dealt with someone who was anxious or agitated? I know I have. And they're fiddling with stuff, and they're constantly moving, and so their attention span is really short, and so you have to learn to work with them. It talks this talks about. I did not mean to skip over that, guys. Give me 1 second. I need to go back. Give me 1 second. Because this is something that's very important. And it's excited delirium. So we talked about what delirium is and what agitation is. And then the symptoms of delirium: hyperactive, irrational behavior, vivid hallucinations, and I'm talking very vivid hallucinations. They can be hypertensive, they can be tachycardic, diaphoretic, they'll have dilated pupils. And then you need to be calm and supportive and empathetic. Approach the patient slowly and respect the patient's personal space. Limit physical contact, and do not leave the patient unattended. Very key. And if someone is medicated for that, also you need to watch out for an alteration in any of their ABCs. Use careful interviewing to assess the patient's cognitive functioning. Determine the patient's ability to communicate. A lot of times these patients are not going to be able to communicate. And then observe the patient's appearance, dress, personal hygiene. Those may be very altered. If the patient has overdosed, take all medication bottles or illegal substances to the medical facility if you don't have time to note them. Transport the patient to a hospital with behavioral health facilities, and refrain from using the lights and siren, because what's lights and sirens going to do to this kind of patient, to your cardiac patients, to any of your patients in distress already, it's going to stir them up. And with these kind of patients, you don't want to do anything to trigger them to have more problems. And then if the patient's agitation continues, ALS can intervene, and they can do what they call a chemical restraint. And then excited delirium can lead to sudden death. So you want to be very careful with these patients. We're not out there to kill these people, are we? This talks about restraints. If you restrain somebody, you have to watch them, and you really, you're going to be with them in the back of your ambulance, and you've restrained them. You better note it, why you've restrained them, how you restrained them, how long you've restrained them, and if you get to the hospital and you transfer them over, and the staff want you to continue the restraints, you need to make sure they know that, because there are requirements for the hospital staff for patients who are restrained. So, and when we do restraints, we have to do a quick release restraint. Do you remember what that is? That if you pull down one time, it releases it. And there's a reason for that, because if you need to do something urgent, you don't need to go, oh my God, I got 10 knots in this and I can't get them out. And then don't forget that we need to get our resources to help us when needed. I'm not going to go more into the restraints because we've discussed that in depth, I believe. And so the potentially violent patients account for only a small percentage of patients undergoing a behavioral crisis. You have to look at their history, look at their posture. Do they look like they're going to attack you? And I've had patients growl at me before, and I'm just like, yeah, that was an indicator that's like an animal right there, and they were very irritated and very violent. And just because someone's not, if they're not mentally altered, doesn't mean that they won't come out after you. We talked a bit about the scene, make sure the scene's safe, the way that your body language, your nonverbals, physical activity, and it's not just your physical activity, it's their physical activity. And sometimes these people who have behavioral issues are very strong, extremely strong. And I'm telling you, there are people that are smaller. Y'all know Deanna, how little Deanna is. There was a patient that was smaller than her, and it took 12 people. I'm not exaggerating. 12 people to restrain her because she was going to hurt herself. And it was, I'm not lying, 12 people on someone that small. They can be very strong. I'm going to keep going, talk a little bit about depression. And depression is the single most significant factor that contributes to suicide. So if someone is depressed and they tell you, man, I just can't get out of this depression, I can't just get out from under this, don't just go and think they'll be okay, because they might be one of the statistics tomorrow. So being able to assess that, and when you have patients, and there's a stigma that goes a lot of times with these behavioral issues, and it's just like, I'm just not spending time here. Do you want to go to the hospital or not? Don't set yourself up for failure that way. That will be a big failure. If that patient goes out and commits suicide, and you were there yesterday, or you were there that morning, and now it's evening and they've committed suicide, that is not going to be in your favor. And don't think that people, when people say they're suicidal, they're crying for help, they're asking for help. They may not act like they're asking for help, and they may be fighting you, saying, I'm not going there. You cannot leave them. You cannot leave them unattended. And just because law enforcement comes to a scene and says, well, I think they're okay, you better make sure that you've done your job. And if there's a question, guess what? You have resources to call. I mean, you call MedCom, CV's available 24/7. So, you know, you have those Fire Medic 1, calling Fire Medic 1 out and going, look, I'm not so sure about leaving this person alone. Let them make a decision. Let them make the calls. Just the warning signs, if they're tearful, sad, they have deep despair or hopelessness, avoiding eye contact, speaking slowly and projecting a sense of vacancy, or they're unable to talk about the future, there's a suggestion of suicide, or they're having any plans related to death. If they say, I just want to end it, I just want to kill myself. Okay, I know that must, you know, that has to be very difficult for you, but do you have a plan? Have you decided how you would do that if you were gonna commit suicide? Yep, got plenty of pills, getting ready to take them before I called y'all. Do you think you need to leave that person alone with pills in their house? No, you don't. If they say, well, a lot of times your men will shoot themselves. Women typically do not shoot themselves, but in a course that I took at Rescue College, forensics and EMS, there was a state trooper that worked with all the crime-related things, and he said that he had more women that had shot themselves than that took drug overdoses. That's unusual. That is an unusual situation. Women typically don't want to have their face damaged or something if they're going to die. This just talks about risk factors for suicide. If you don't understand risk factors for suicide, please see me after class. I'm glad to discuss that with you. We're not going to go into all of those stuff. We won't have time for all of these things. PTSD is post-traumatic stress disorder, and that happens to a lot of our returning combat veterans. It happens more often to veterans than not. And the things that our veterans see, we see some bad stuff, and not all veterans see really bad things. Not all of them go to combat areas where they see people who have legs blown off, who are dead and their body is in 10 different pieces, or there's nothing even left there of them. I can only imagine the horror of what a lot of our soldiers see. I mean, they see horrific things and have to go out there, and it's like they're taught, hey, go ahead and give them this. If they're dying, give them this. Let them die and, you know, be comfortable. And how would that make you feel if you had to go out there and you're like, I know they're dying, but I want to give them this medication that's probably going to make them die faster. And you're just like, now there's your buddy that you went through boot camp with, who you went through high school with, or whatever. And, you know, there's a camaraderie. They always talk about the camaraderie in the military, and they have very, very, very strong attachments. And then, you know, but post-traumatic is a big thing. Don't underestimate people who have post-traumatic stress. The medico-legal considerations, EMS, are more complicated with patients undergoing behavioral health emergencies. There are legal problems, and they're reduced with the patient consents to care, because if they're not with it, they don't know what's going on, they can't consent, they can't do whatever they need to. And so you need to make sure that you cover all the things that you need to cover, that you're thorough in your assessments. You're thorough in if someone's going to refuse, are they competent Are they cognitive? And you need to really know those things, because if you get someone to sign a refusal that was not competent to sign a refusal, that doesn't mean that you're off the hook. And so you have to show all those things. But behavioral emergencies are on just about every single call we go on. I'm going to say that again. And so you have a number of things that you have to deal with. And even getting a patient to go to the hospital sometimes, you may have to coax them to go, look, you really need to go because you could be having this. And then getting them in the back of the ambulance, make them comfortable, get them comfortable, and have a good rapport. And even putting your hand on an arm, you have to be careful with what patients you do that with, but even putting your hand on an arm will show compassion and that you really truly care about them. That's the big things that I have for you. Jane's getting ready to do her last lecture, and then we'll be cut. Y'all have any questions about behavioral issues? What in your mind would make you think would be the most critical things about a behavioral issue, a behavioral patient? Anything?
Physical harm.
Yes.
That's about it.
Physical harm, safety, and sometimes, no matter what you do, you're not going to get rapport with them. Not every patient are you going to get rapport with.
That's okay.
Yeah, but you need to try to. Don't have this, I don't care if they agree with me or they like me or not, because that does matter. And it makes, and it leaves an impact on other people around you. If you have a little smart attitude, that's not going to work in EMS. If you have a little sarcastic attitude, don't do healthcare. Don't be involved in healthcare. If you have I don't care if they go or not, and if you don't have compassion, you don't need to be in healthcare. It's not something that I can teach to anybody. But anyway. Okay, I'm done.